Hello, and welcome to AFSPA Live, our monthly digital broadcast designed to give AFSPA members and eligible federal employees a place to ask questions and get answers about past AFSPA Talks topics, their benefits, and wellness needs. There are 3 primary ways you can join our broadcast. Join us live by clicking the link in this video description and following the instructions to allow access to your camera and microphone. Then, a show moderator will be available to assist you further. You can ask your question through the chat box on whichever social media platform you're streaming AFSPA Live, YouTube, Facebook, or LinkedIn. If you're not able to join us live, call our toll-free line prior to the broadcast at 888-435-0757 and leave our team a voice message that we may play back and answer live on air. Just tell us who you are and the question you'd like us to answer. I'll see you at the next AFSPA Live.
Hi, everyone. Welcome to AFSPA Live. AFSPA Live is a live video broadcast Q&A session that we hold at the end of the month on Thursday, every month. I'm Maddie Norton, and I'll be the moderator today. I'm a communications coordinator at AFSPA, and today we will be discussing childhood obesity with AFSPA's COO, Kyle Longton, and our special guest, Dr. Sandy Sara.
Excellent. And Maddie, thank you very much for introducing the topic today. This is something we've wanted to tackle for a while. And because there have been some changes in recent months about sort of guidelines and recommended treatments and so forth for childhood obesity. And we are very, very fortunate to have Dr. Rinku Santasara with us today. She is a pediatric endocrinologist in practice in Virginia, having obtained her medical degree at the University of Virginia Medical School. And she's also the head of the Pediatric Obesity Subcommittee for CVS Health. So she not only sees this in her practice every day, but she's been engaging in the policy and the changes daily as well. So I wonder, Dr. Santasara, if you could just start us off with a little bit of an overview of sort of what those changes are that have occurred from the American Academy of Pediatrics and others in recent months.
Of course, Kyle. And thank you for having me. So I did want to mention that, I'm a pediatric endocrinologist. I'm also a pediatric obesity certified physician, and there's very few of us who are certified in obesity medicine and pediatrics. And, I've spent my career working with children with diabetes, mainly type 2 diabetes. And we see that in practice and really across the country that obesity rates are increasing dramatically in children and increasing in adults as well. But the AAP recently changed their guidelines earlier this year. And for the last 2 decades, we really haven't seen many changes. In fact, as a pediatrician, and even when I was in training and beyond, we used to say to our patients that obesity was a problem, and we would plot their BMIs and plot their, heights and weights and talk about weight at every visit. However, we had very limited medications or therapies we could offer outside of counseling on lifestyle. And so as a pediatrician, I would counsel my patients from really very early on, school age and beyond, about diet changes that they could make and lifestyle changes that they could make, and talk about diet, exercise, and refer them to nutritionists. We really didn't have many other options, to be honest. And the AAP has recognized now that after 2 decades that alone doesn't work. And having patients come back year after year for weight checks really isn't making a difference. And most recently, we have had new medications, we have had some surgical options, and we have had different ways that we can help to manage obesity. And obesity has now been defined as a chronic illness, especially for our pediatric population. And that is why the AAP has changed their guidelines to say that instead of saying, let's change your diet and exercise, we really need to, as a medical community and as a family unit, when we talk to our families, focus on other things that we could do and really take a holistic approach and really talk about maybe the use of medications from very early on when we talk about obesity and weight. So that's been the biggest change.
This is also interesting to me because I went to school during Michelle Obama's big thing of making the school lunches healthier because they saw childhood obesity being a large problem, obviously. And I would love for you to talk about the statistic you shared with me when we met earlier about by 2060, there's like millions of people that will eventually have type 2 diabetes.
Yeah.
I'm still thinking about that statistic since you said that.
Yeah, so really, the obesity prevalence has been increasing in age. So, if we look at, from 2015 to 2016, the prevalence of obesity in kids was about 13.9% for children, 2 to 19. And then, that significantly increased. So it's about 20% in 2018. And the statistics really say that, if we continue to increase obesity rates at the same type of, prevalence, that by 2035, there's going to be 51% of the world's population, or about 4 billion people, who are expected to be overweight or obese. And out of those, about 60 million of them with type 2 diabetes. So really, this is why the AAP has been sounding the alarms, and they've written that in their position papers, that the prevalence of both obesity and complications of obesity are rising at an exponential rate. And our current guidelines that we had, or our previous guidelines that we had, were not addressing this and really haven't made a difference. Not to mention, the COVID-19 pandemic significantly affected the lives and routines of children and adolescents and doubled BMI rates in a lot of children because they were home, they weren't participating in activities, there was access to food. Sometimes there was not access to food. For example, there was food insecurity, and so some patients were individuals were getting food, not at, healthy school lunches, but they were getting other food that the family, could afford to buy, which were high calorie foods. And so this really has led to a significant uptick in obesity in children.
And, what kind of factors lead to a diagnosis of obesity for a child? And do the factors change from one age to another?
Yeah, so when we talk about obesity in children, we really talk about a body mass index. And so when we're talking about body mass index, it's different in children than in adults because children are growing and developing. And so their weight changes for their height. And so for the body mass index looks at the weight divided by their height squared. And so when we look at weight, and BMI, we really look at BMI above the 85th percentile, meaning if you take 100 children and you plot their weight for height at that same age, if your weight for height is higher than 85% of them, you're considered overweight. If your weight for height for that same age group is over the 95th percentile, you are considered obese. And over the 120th percentile is considered to be severely obese for children. And so when we look at the diagnosis of obesity, we're really talking about body mass index for children in percentiles. So, that's really important to note. And BMI is not a great tool. It is the best tool that we have for children. It doesn't account for their body composition. For example, muscle weighs more than fat. It really doesn't account for that. It doesn't account for ethnic and racial differences. For example, Asians like myself, we may have a body mass index that's a little bit lower, but still considered to be in that obese category for our ethnicity. Mm-hmm. And so that's really, when we talk about obesity and diagnosis, that's really what we're talking about for children.
All right. And, you talked about the BMI being like the main tool so far for diagnosing it. Are there any other lab tests involved in the diagnosis or in determining the treatment method?
Yes. So when we look at, obesity and increased BMI, there are several complications that result from the diagnosis of obesity. For me, as a pediatric endocrinologist, diabetes being the most prevalent. And so
Mhm.
there are lab tests that the AAP recommends doing at a certain, BMI over the 85th percentile or BMI over the 95th percentile, mainly to look to see, are they developing comorbidities? So there's no lab test to say that a patient is obese, but there are
Yeah.
lab tests to say, is obesity having a long-term impact on their overall health? So hemoglobin A1C, for example, is a measure of blood sugar control over a 3-month period of time. And the recommendation is to check the hemoglobin A1C to see if this child is developing prediabetes or diabetes. Cholesterol levels also are checked. Um, the liver is another area which stores fat, and so checking liver function tests to see if there are complications associated with obesity are important to address in children as well. But lab testing in particular to say, is this child obese or not? There are not. There are complications that we see associated with obesity.
All right.
I, I
And
have I have a quick follow up on that also. Do you look at thyroid tests also just to see if there are if that's playing a role in obesity or in at least in BMI?
Yes. So, we do address the thyroid function test to say, is the thyroid abnormality causing a child to be obese? Now, in children, hormonal evaluation, people talk about Cushing's disease as causing obesity or thyroid disease. In children, really important to notice that children with a thyroid problem don't grow well in height. And children with Cushing's disease or elevated cortisol levels don't grow well typically in height. Children with obesity grow fast, they go through puberty early. So oftentimes we're seeing children who are obese or overweight and they are tall for age. It is unlikely to be related to their thyroid. But certainly we check that. And as pediatricians, we check that. We check to see if there's any hormones that are contributing to their weight gain. And the other complication with obesity in children is that we're seeing earlier and earlier stages of puberty, especially in girls, and we saw an uptick in that in the during the COVID-19 pandemic. So girls are going through puberty faster; they're getting their periods earlier, and that's really been thought to be related to obesity, in addition to some genetic factors.
Thank you.
and speaking of genetic factors, we have a LinkedIn user who has asked, when you speak to ethnicity, is it based on cultural differences, diet, physical activity, etc., or has genetic testing been done that verifies the obesity trends in varying ethnicities?
Yeah, so it's not really related to, more genetic testing, but for example, when we look at the waist circumference, we can look at waist circumference and say that there are certain waist circumference criteria or BMI criteria that are different in different ethnicities. It's really not related to, the rates of weight gain or BMI criteria. Um, we don't look at diet or physical activity when we plot BMI. We really look to see, are there variations in different ethnicities that we can see, cross culturally, and what are those BMIs?
All right. And it looks like from the same user, we have a question as well about stress. Is anyone looking into stress and the psycho or physiological effects of stress on children? She says, we all know how stress affects women. Is it the same for children?
So when we talk about stress, there's different levels that I'm asked about with regards to stress as related to weight gain. If we're talking about stress, and we'll take an example of the COVID-19 pandemic, right? So we were stressed out at home. We had psychologically, children were out of their routines. So a lot of the things we talk about with regards to stress in that example talk about where do you go for comfort? Do you go to food, or do you have more time on the TV or their screen times, limited physical activity. And so, yes, in that respect, that type of stress has been linked to weight gain. Other questions I usually get are on, stress related to stress hormone like cortisol production. And there are higher levels of cortisol production. For example, there were a lot of children who had depression and anxiety also during the COVID-19 pandemic. And so their cortisol levels, if you were to measure them, would be a little bit higher, not to the point that they're pathologic. But does that contribute to weight gain? We don't know, but we do think that some of the stress that children encounter, especially during the COVID-19 pandemic, did contribute to some of that weight gain. But it's not measurable to say if we did a lab test and measure their cortisol levels, would those be higher and would those need treatment?
Right. And I was doing some research on this topic last night, and I saw a lot of things of people worrying about the new guidelines from the AAP, and is there a concern for disordered eating to increase among adolescents?
Yeah, so I'm very happy that you asked this question. There has been a lot of debate in the medical community and the pediatric community about the new guidelines talking about weight loss medications, and is this going to contribute to disordered eating? This is a common concern for all pediatricians. And disordered eating really refers to a wide range of irregular eating behaviors and attitudes that can have a negative impact on the child's physical and mental health. So examples of disordered eating are extreme dieting or calorie restriction, similar to anorexia or somewhere along that spectrum. Skipping meals, particularly breakfast, preoccupation with weight and body image. So excess concerns about, what is my size compared to that of my peers. Over exercise is, compulsive exercise or exercise if you eat something and you just don't want to gain weight. Food avoidance, and then binge eating and purging. So these are all examples of disordered eating. It's essential to recognize and address these issues because the factors that are related to disordered eating include societal pressures really to conform to unrealistic body standards and peer influence, stress, body, family dynamics, personal factors like low self-esteem. And adolescents are really vulnerable to these pressures. However, I will say that as a pediatric obesity medicine specialist and a pediatric endocrinologist, and as a member of the AAP, now the AAP has looked at this, and it's important to note that healthcare guidelines are developed based on the latest scientific research and expert consensus. They're designed to promote the health and well-being of children and adolescents. And I will say as a practicing physician that oftentimes disordered eating results when patients, and especially teenagers, don't know what else to do to control their weight. And so if we have a medication or a therapy, or sometimes even surgery in extreme cases, that's going to help and help them with the results that they want, sometimes they don't develop those disordered eating patterns. And it's important to be vigilant about those disordered eating patterns and set realistic expectations for adolescents. But I've actually found the opposite, that when we don't have treatments to offer, we have adolescents developing eating disorders.
And I really appreciate that when you're talking about they may not know what else to do, and parents may not know how to help them in some cases. And I just want to mention for Foreign Service Benefit Plan members who are listening, there is support available for parents who may be wishing to find a way to support their children through our Lifestyle and Condition Coaching Program, LCC. So there is a program there where parents can get some advice and some guidance on how to best support their teens. So if that is you, please check that out for some more information.
And kind of on that same topic, weight is such a sensitive topic, like we were discussing, and how, as we've had questions from parents say, like, how do I discuss weight with my child without having without it being a negative topic or having a negative impact on them, especially if they do tend to be overweight or even obese?
Yeah, so discussing weight is a really sensitive topic, not just for parents, but for pediatricians as well, and for us in the healthcare community, especially for young children, teens, and even, older young adults, it's very important. And even as adults, it's a very sensitive topic. So it's very important to talk up to teens and children in general in a very sensitive manner. Usually I say, when you want to talk about weight with your child, choose the right time and place. So don't talk about it in front of their friends. Maybe talk about it in private, one-on-one, in a comfortable setting when the teen is relaxed, and really focus on more of a positive discussion without blaming the child, expressing your love and concern, but really talk about health
Mhm.
and, encourage your child to explain how they feel about their weight and about health and why health is important. Why is it important to make healthy eating a priority? Why is it important to increase physical activity? And really focusing on setting realistic goals. And I often tell my patients that we're not expecting you to lose, 10 pounds in a month or 20 pounds in a month or even 5 pounds in a month. We really want to set realistic goals. So what are the habits that we can set? And really, for parents, being a role model, because children often learn by example. So being a positive role model for the children and practicing healthy habits in your own life. So instead of reaching for a sugary drink, maybe focusing on water or replacing that in the home, making simple changes, and really for children and teens, involving them in the decision making. So allow your child to be a part of the decision making in meal planning, physical activities, ask for their input. And then finally, if those things aren't working or you want, further help, to seek professional guidance. And you mentioned some of the, programs in the federal plan, but really looking to see if there's nutritionists or other programs that are available. Unfortunately, from, from a doctor's perspective, I would say that weight and weight concerns and elevated BMI really, can't just be managed in the doctor's office. This is a community effort, it's a family effort, it's a social effort for all of us. And so I think that's important to recognize that really we are not to blame that individual, but there's a lot of factors that are involved.
And, we talk about, how you can enforce a healthier, or not, maybe not enforce, but incorporate a healthier lifestyle, at home. But what has the AAP recommended for what weight loss drugs, or even you mentioned in extreme cases, bariatric surgery? What are they saying about that? What is the AAP saying? And how does a doctor or physician determine the right path forward when it comes to those two things?
Yeah. So first, I'll say that the AAP is saying that they have not taken away the guidance about intensive lifestyle modification. So that is first and foremost. So even if you're going to consider bariatric surgery, there's a recommendation start with intensive health and lifestyle therapy. So that's very important. Um, the AAP is saying at this point that the patient, the family, and the healthcare provider, in sometimes a multidisciplinary team, which includes psychologists, therapists, nutritionists, social workers, really should be involved in the decision-making process. The treatment guidelines, really, we shouldn't be waiting. So we should be focusing on the therapy really right away, if that's what the family wants. And really focusing on what types of treatments the child or the family wants, and really talking about the side effects of the therapy and what the expected outcomes are. For a long time in pediatrics, we have had very limited medications that we could offer. As a pediatric endocrinologist, when I would get referrals for patients with obesity, the only medication I had to offer was metformin, which is a diabetes medication, a pre-diabetes medication, which is not a weight loss drug, but it's the only thing we had that was available. There was a lot of stigma around starting some of these medications in the past, and that's why it really hasn't been done. And now the AAP is saying that there are, a handful of medications that we have in our arsenal that we can offer with the family's understanding of what the side effects are and what the therapeutic goals are, and we can start those right away. And if the families do want to have, consideration for bariatric surgery for, elevated BMIs, there's guidelines to say when we should refer. And the patients who are going for bariatric surgery really need to be in a medical home or with a bariatric surgeon that has extensive experience with operating on children, but has, at least 12 weeks of lifestyle modification therapy built into the program. Because we know that if we're going to do surgery on our young children, that we want them to develop healthy habits so that the surgery is successful. So the AAP's main guidelines are that at this point we can't wait. We need to have a family-based approach, and we can offer medication and bariatric surgery to those patients who need it and who are interested in exploring those options.
Right. And I'd kind of like to ask Kyle, as foreign service benefit members, does our plan cover bariatric surgery and weight loss drugs? What are the requirements? What are the, qualifications?
Sure. And the answer to that is, in both cases is yes. The Foreign Service Benefit Plan does provide coverage for bariatric surgery. And some of the guidelines for that, I think Dr. Sandasara has been involved in setting, but we do require stateside that people seeking surgical treatment for obesity, whether bariatric surgery such as gastric bypass, gastric sleeve, and so forth. We do have certain pieces that have to be met, including a weight loss program that's multidisciplinary, combining diet and nutritional counseling with an exercise program and a behavior modification program, as well as certain sort of clinical benchmarks that have to be met, including a BMI equal to or greater than 40 or a BMI equal to or greater than 35. And when we're talking, those are the requirements around the world. Stateside, for members seeking surgery stateside, it does have to go through the prior approval process, and usually the doctor can help you with that, especially if they're in network. Overseas, we don't necessarily require the prior approval, but we will require documentation to show that all of those requirements have been met before we pay the claim. So you're also welcome to reach out to us for what we call a predetermination. Say, I'm looking at this surgery, here's the evidence of what I've done to meet these and so forth, and get that ahead of time so that you know it would be approved. When it comes to weight loss drugs, yes, we have been covering weight loss drugs for about 2 years now, maybe even a little bit more. We just had a check-in last week, and to look at the first half of this year, I think we have about 700 members in Foreign Service Benefit Plan who are on weight loss drugs. And those are the drugs that are specifically approved for weight loss. There are some drugs that are very similar out there that are approved for diabetes treatment, and some that have an effect of weight loss, and some people have used them specifically for weight loss and so forth. We have a very rigorous, let me put it that way, prior authorization process in place for weight loss drugs. And so we do see an approval rate north of 50%, but that is because people who are being prescribed these drugs, in most cases, are meeting those requirements that are set. So that is a discussion that to be had with your doctor. The doctor can also provide the documentation we need for the weight loss drugs or for the bariatric surgery. But I just want to emphasize again what Dr. Sandasara said, which is that this at any age, we're just talking specifically about children, but also for adults, requires a multidisciplinary approach. It requires the commitment of the patient, their community, including their healthcare providers, but also could involve other professionals who can provide that support, including registered dietitians and more. And we do provide coverage for nutritional counseling. Separate from this, we do provide a number of programs to support members for weight management, as well as coaching programs to help with weight management and, again, supporting children with diabetes. With obesity. Mm-hmm. Diabetes as well.
Yes. And I think that's really important. Just like you were talking about, everything that we've talked about is like there's multiple steps to it, and it takes a community to handle something like this, and make sure that everyone's taking the right steps. And I think my final question would be, is it possible for a child, especially with the BMI scale, to be considered overweight or even obese, but still have, maybe great blood work, or, they're in sports or they're doing something to make sure that they are still considered healthy. Is that possible? Or I've heard people say like, I'm completely healthy. I can still do things on my own and everything, but they still might be considered obese or overweight. I would love to hear your thoughts on that, especially for children, obviously.
Yeah, so it is very possible for a child to be considered overweight based on their body mass index and still be considered healthy. Again, BMI is a screening tool. It calculates the individual's weight in relationship to their height, but it doesn't provide a complete picture of their overall health. So there are certain reasons that children may have an elevated BMI and still be healthy. For example, BMI doesn't distinguish between fat mass and muscle mass. So children who are active and engage in sports or physical activity may have a higher BMI because they have higher muscle mass, and muscle does weigh more than fat. And so a child with a healthy amount of muscle may have a higher BMI without excess body fat, and they're healthy overall. Growth and development in children is very important. So in puberty, children experience temporary increases in their BMI before they start to grow and develop. And so they could also be very healthy during that time frame. Genetics play an important role. So some children may naturally have a higher BMI due to their genetic makeup, even if they maintain a healthy lifestyle. And so we see that, and their body composition is different. So really the distribution of the fat mass matters more than the overall BMI. And that's really important to emphasize. Now, general pediatricians and even specialists really have a BMI as the tool, and often fat mass is not measured in the office. And so that's why I think it's important to understand that this is a screening tool, not necessarily a be-all and end-all. But a child can be overweight by BMI standards and also not exhibit any health risks or obesity-related conditions. Their blood pressure could be normal. Their cholesterol could be normal. Their insulin, levels and, diabetes risk could be low. However, it's important to understand that these are screening tools, and each child must be taken, looked at individually to say what types of therapy does that child need. And it may not be anything, but I think it's important for us to address and say, this is what the BMI looks like. And for this child, there is a risk versus for another one that there may not be.
All right. We're at 11:32 right now, and I feel like I've learned so much today. I don't know about you, Kyle. So I just want to say thank you so much, Dr. Sandasari. This has been incredible. If you're catching the tail end of this, you can watch the recap almost immediately at youtube.com @AFSPA Cares. We'll be there. And you can watch any of our past AFSPA Lives or any of our podcast episodes, AFSPA Talks. Look out for a new episode this coming Monday, all about hinge health and pelvic floor therapy. Once again, thank you so much, Dr. Sandasari, for joining us. This has been incredible. Thank you, Kyle. And this has been AFSPA Live.
All right. Thanks, everybody.
Thanks for watching our broadcast. Join us again the last Thursday of every month at 11 a.m. Eastern. Also, don't forget to look for AFSPA Cares on all of our social media channels: YouTube, Instagram, Facebook, and LinkedIn.